Anorexia nervosa carries the highest mortality rate of any psychological disorder, higher than depression, higher than any other condition in the diagnostic manual. Yet eating disorders remain widely misunderstood as simply extreme dieting or vanity taken too far, obscuring a complex biopsychosocial condition involving genetics, brain chemistry, and cultural pressure that requires specialized, evidence-based treatment. Anorexia nervosa is characterized by persistent restriction of energy intake leading to significantly low body weight relative to age, sex, and developmental trajectory, combined with intense fear of gaining weight or becoming fat even at a dangerously low weight, and a disturbed experience of one's own body weight or shape, including denial of the medical seriousness of one's low body weight. Anorexia carries the highest mortality rate of any psychiatric disorder, resulting from both severe medical complications of starvation, including cardiac failure, and significantly elevated suicide risk. Bulimia nervosa is characterized by recurrent episodes of binge eating, consuming an objectively large amount of food in a discrete period while experiencing a sense of loss of control over eating, followed by recurrent inappropriate compensatory behaviors to prevent weight gain, including self-induced vomiting, misuse of laxatives, fasting, or excessive exercise, occurring at least weekly for 3 months. Unlike anorexia, individuals with bulimia typically maintain a body weight in the normal or above normal range, which can make the disorder less visible and more likely to go undetected by family and healthcare providers. Binge eating disorder involves recurrent episodes of binge eating, similar to bulimia, accompanied by marked distress about the binge eating, but without the regular compensatory behaviors, vomiting, laxative use, excessive exercise, that characterize bulimia nervosa. Formally recognized as a distinct diagnosis only in DSM-5 in 2013, binge eating disorder is now recognized as the most common eating disorder in the United States, more prevalent than anorexia and bulimia combined, and affects a more demographically diverse population, including higher rates among men than the other eating disorder diagnoses. Twin and family studies find substantial heritability for eating disorders, with estimates around 50 to 60% for anorexia nervosa, indicating meaningful genetic contribution alongside environmental factors. Certain personality traits consistently predict elevated eating disorder risk, particularly perfectionism, especially the tendency toward rigid, self-critical standards, high negative affect and emotional sensitivity, and traits related to obsessive-compulsive tendencies, which appear to interact with environmental triggers, including dieting behavior and weight-related teasing, to precipitate disorder onset in vulnerable individuals. Sociocultural risk factors play a substantial documented role in eating disorder development, including exposure to thin ideal media imagery, which longitudinal research links to increased body dissatisfaction and disordered eating behavior, participation in appearance-focused activities and sports emphasizing low body weight, including gymnastics, ballet, and wrestling, and experiences of weight-based teasing or bullying during childhood and adolescence. Natural experiments, including the documented rise in disordered eating following the introduction of Western television to previously unexposed populations, provide compelling evidence for the causal role of sociocultural exposure. Family-based treatment, also known as the Maudsley approach, is the leading evidence-based treatment for adolescent anorexia nervosa, explicitly empowering parents to take temporary, active control over their child's eating and weight restoration during the acute phase of illness, rather than treating the adolescent individually or assigning blame to family dynamics, as earlier family therapy models had done. Randomized controlled trials show family-based treatment produces meaningfully higher rates of full weight restoration and remission compared to individual therapy approaches for adolescents specifically, though its applicability is more limited for adult-onset cases. Enhanced cognitive behavioral therapy for eating disorders, known as CBT, is the most empirically supported treatment specifically for bulimia nervosa and binge eating disorder, directly targeting the maintaining cycle of restrictive eating, binge eating, and compensatory behavior through structured self-monitoring, regular eating pattern establishment, and cognitive restructuring of distorted beliefs connecting self-worth to body shape and weight. Randomized trials show CBT produces full remission in a substantial proportion of bulimia and binge eating disorder patients, generally with more favorable outcomes than treatments for anorexia nervosa. Eating disorders are complex biopsychosocial conditions, not simple lifestyle choices or vanity, carrying serious medical risk and requiring specialized evidence-based treatment. Understanding the distinct diagnostic categories, genetic and sociocultural risk factors, and treatments tailored to each specific disorder is essential for recognizing and responding appropriately to these often misunderstood but highly treatable conditions.